Okay, everyone, I think we'll get going shortly. I'd like to introduce Dr. Seana Nelson, who did a year of preventative ambulatory cardiology with me. And Seana is going to have a whirlwind review of some lessons learned during a year of preventive cardiology and hopefully share some knowledge and translate so we can all care for patients better. Seana?
Hello. Okay. Thank you. And thank you for having me speak today. So as Dr. Abramson mentioned, I just finished a year of prevention with her, and I wanted to do a kind of a summary of what I learned in a way that is maybe a bit more digestible for individuals who don't do this every day, and in a way that maybe allows someone to use this as a quick reference in the future in a patient that they're seeing in clinic. And so hopefully kind of throughout the talk, there'll be a few little clinical pearls here and there about how to maybe apply it to a separate case, for example. But hopefully this will allow us to all care for our patients better. And so today I'm going to be basically applying evidence-based lipid-lowering therapies, and I want to make sure that we understand the practical considerations for prescribing these in secondary prevention. We want to apply cardiometabolic therapies to optimize secondary prevention in patients with diabetes, obesity, and chronic kidney disease, and we want to recognize emerging and overlooked risk factors in primary prevention. And many of us in cardiology and hopefully in the rest of medicine understand that cardiovascular disease is quite prevalent. Nearly 1 in 12 Canadians over 20 are living with cardiovascular disease. Nearly 14 of these patients die every hour. And the death rate increases in heart disease. About 4.5 times higher in those with previous history of heart attacks or MI, and nearly 6 times higher in those with heart failure. And understanding that most patients with heart failure will have underlying coronary disease. And while the acceleration rate of developing heart disease may be slowing, cardiovascular disease continues to rise in Canada. And this is data from fairly recently to recent chronic disease surveillance data from 2024. And so in the cardiac prevention clinic, we're appreciating that in individuals with previous cardiovascular disease, they're at increased risk for recurrent events. So individuals who have had 2 events in the past are much more likely than those who've had just a single event with risk factors, and those with ongoing risk factors are at higher risk than those who've had no risk factors. And so the management that we're trying to do is modify anything that's modifiable. So obviously we can't affect age, we can't affect what's happened in the past, and we can't affect genetics, but we can try and lower the risk associated with diabetes, hypertension, CKD, ongoing smoking risk, persistently elevated LDL, and congestive heart failure. I think there's someone who may be not muted.
Good.
For the cardiac risk factors, so you have hypertension, diabetes.
Please mute. Thanks.
Thanks. Okay. And so anyway, so we're trying to mitigate or reduce the risk associated with all of these additional risk factors. And so in secondary prevention, we can think about, a large flow of, stopping the risk that a patient may be Reducing risks associated with hypertension. I think it's pretty, foundational now that most of us are targeting sprint level blood pressure target, so blood pressure less than 120. And then we kind of get a little bit gray with ongoing risk reduction in dyslipidemia and diabetes, despite having fairly good evidence to do so. And so I'll be talking today about how to further lower cholesterol risks and then address risks associated with diabetes. And then for your reference, there's additional risk reduction we can do by addressing multiple vascular bed atherosclerosis or in higher risk patient populations, such as those with peripheral arterial disease. And so if we kind of focus in on what I was discussing, so we'll go down the dyslipidemia or the cholesterol lowering pathway. And this is, pretty much right out of the guidelines and maybe just providing a little bit more detail around that. And so in patients, we're effectively trying to get below these values, LDL less than 1.8, non-HDL less than 2.4, and ApoB less than 0.7. And there's, I think an easy way of talking about it is a target. In the guidelines, they talk about it as a threshold to intensify. And really what that means is just that most of the studies used about these values to add on additional non-statin lipid lowering therapy. And so most of our lipid lowering therapy is what we recognize and do all the time, and that's the high intensity statin. It's common, available, very effective, very inexpensive, and can lower LDL cholesterol by about 50%, triglycerides by 25%, ApoBs by 40 to 50%, can reduce CRP, can increase mildly your HDL or patient's HDL. And then second to that would be addition of ezetimibe. Ezetimibe is, again, very readily available, relatively inexpensive with the use of a limited use code, and can further reduce someone's cholesterol or patient's cholesterol by about 25%, ApoB by 15 to 20%, and Lp(a) mildly trivially in high CRP levels by 15 to 20%. And then we have the PCSK9 inhibitor drugs, and these drugs, I think, have gotten a lot of media attention. Obviously, they're extremely effective in our system. They're quite expensive. I mean, not just in our system. They are quite expensive in our system. They're a little bit less readily available. And so if we think about a case, for example, let's pretend we have a patient, a Mr. B. He's a 60-year-old man. He's had a recent NSTEMI. He has normal cardiac function. Prior to his MI, he didn't have a past medical history, and then he was discharged home on dual antiplatelet therapy and atorvastatin, and you're seeing him in follow-up. His exam is normal, his BMI is normal, and his cholesterol profile isn't too bad, but reminder that he's on maximally tolerated statin already. And so we're happy with his BMI, we're happy with his blood sugar levels or HbA1c, but unhappy with basically the rest of his cholesterol profile, both LDL components, ApoB, non-HDL, as well as the triglycerides. And so going back to basics, this is out of the 2021 CCS dyslipidemia guidelines in patients with atherosclerotic cardiovascular disease. If a patient is above the threshold of an LDL greater than 1.8, ApoB greater than 0.7, and non-HDL greater than 2.4, then we go on and add on, we go on and add on either ezetimibe or PCSK9 inhibitors is what the guidelines would say. However, in our system, in order to get access for PCSK9 inhibitors, practically a patient needs to have been on ezetimibe. And so, and furthermore, most patients will be able to achieve below these targets on ezetimibe. And so what is ezetimibe? Ezetimibe is a molecule that reduces LDL absorption through the intestine, and it provides about a 25% further LDL reduction when added to statins. Most patients, nearly 80% of patients on combo therapy of high intensity statin and ezetimibe will achieve an LDL of less than 1.4. And the clinical trial that was the landmark trial relating to ezetimibe in terms of risk reduction was the Improve It trial. And this basically took patients who were 50 years of age who'd had an MI within the last 10 days. On average, their LDL was about 3.2, not on a statin. If they were already on a statin, about 2.6. And patients were excluded if they were on a statin with a higher potency than simvastatin, which was what the trial statin drug was. They were also excluded if they had liver disease or plan for bypass or renal failure. And at the 1-year mark, and then throughout the rest of the study, the average LDL in the ezetimibe plus simvastatin group was 1.4, and which is, really, a lovely LDL lowering and lovely efficacy in terms of lowering. And furthermore, it also demonstrated reduction in primary efficacy endpoint of death from cardiovascular disease, major coronary events, which included non-fatal MIs, unstable angina, bypasses, and non-fatal stroke. And this was basically re-emphasized in meta-analysis demonstrating that in patients who were either on moderate or high intensity statins, that statin plus ezetimibe is favorable to statin in terms of reduction of MACE. And just as a side note, for sort of any patient, secondary or primary, the addition of ezetimibe is a great option in terms of allowing a patient to get to a lower LDL or lower cholesterol target with maybe a less intense dose of statin therapy. And so this is a study, it was the racing trial, looking at nearly 3,000 patients who either had very high risk of cardiovascular disease or not very high risk of cardiovascular disease. And they were effectively randomized to either rosuvastatin 10 and ezetimibe, or just rosuvastatin 20, which is considered a potent statin. And effectively intergroup, they had similar efficacy in terms of lipid lowering, but also cardiovascular events. Numerically, the patients on the combo therapy had fewer events than those just on statin alone. So it's a good drug, not only in secondary prevention, but also in primary prevention, for example, if a patient's potentially not able to tolerate statin therapy. And in terms of its use or prescribing, it's relatively easy, as I mentioned. There's no significant side effects. It's 10 milligrams daily. There's 2 limited use codes, one for patients not achieving target LDLs despite statins, and one for patients who were unable to tolerate statins or they're contraindicated. And so after starting a patient on ezetimibe or any lipid-lowering therapy, the cholesterol panel should be reevaluated at 4 to 12 weeks, and ensuring that patients is now below these thresholds to further up-titrate their lipid-lowering therapy. And so in our patient, we've followed him up in the 4 to 12 week mark. His HbA1c remains fine. His LDL has gone down somewhat, and it's very close to where we would want it to be. His LDL is now 1.9. You may recall that the number we're looking for is below 1.8. ApoB is 0.7, non-HDL 2.7. Triglycerides remain high, and that's to be expected. We wouldn't expect a big change with ezetimibe. And so now we get on to adding on additional lipid-lowering therapy, and that's the PCSK9 inhibitors. And why do we even bother? So there's been numerous studies that have demonstrated that the lower that we can keep a patient's low-density lipoprotein over time, for the longer duration, the less cardiovascular events that they'll have over time. And so if in analysis, when they look at patients who have, or not patients, but studies where they have an LDL-C starting at where our threshold is, the addition of further lipid lowering further reduce cardiovascular events or major vascular events. So the mechanism of action for PCSK9 inhibitors is basically blocking the effect of PCSK9. So what is PCSK9? So PCSK9 is in this this little Pac-Man here. The orange Pac-Man, basically PCSK9, binds to the LDL receptor and basically targets it for lysosomal degradation in the hepatocyte. And in doing so, the receptor is no longer functioning and no longer able to pull in LDL and target it for excretion through the lymph system. And so in doing either inhibition of PCSK9 through a monoclonal antibody or targeting it through an mRNA, basically the LDL receptor is not targeted for degradation. It can still be internalized, but then it's recycled back to the cell surface. And having more LDL receptors basically is functioning as sort of a suction or pulling in more LDL and lowering LDL further. And so one of the landmark trials for PCSK9, and the main one that I'll talk about today, is evolocumab or Repatha. And this trial was the FOURIER trial. And it looked at about 27,000 patients between 40 and 85 years of age with atherosclerotic cardiovascular disease who had an LDL of 1.8 or higher on statin therapy. And they were followed for about 2 years. And the primary efficacy was reduced in those patients on Repatha. And primary efficacy endpoint was a combination of CV death, MI, unstable angina, revascularization. And in Repatha group, the event rate was about 9.8% and compared to 11% in the placebo group. Overall, the primary event rate was reduced by quite significantly, and these results were consistent across subgroups. There was no real difference in adverse event rates, with the exception of a small increase the medication. So both FOURIER and Odyssey, which Odyssey looking at Praluent or demonstrates a reduction in MACE. The numbers are in the moderate range. So an estimated number to treat over 5 years, again, is 30 patients for those on PCSK9 inhibitors. We basically prescribe these in most patients, except for in those with severe hepatic impairment, which I've yet to encounter, or in patients who are planning on becoming pregnant or are planning on nursing. It's dosed at 140 milligrams sub-Q every 2 weeks, or 420 monthly. It's a pre-filled pen. They have to store it in the fridge. If they're going to pay for it out of pocket, it's about 300 to 600 Canadian dollars, depending on pharmacy and location. But if they're able to qualify for the LU code, then they would have a lot of it covered. And filling out this Repatha Ready form, which you actually have to search it. I tried to link it for you, but it's blocked by a password login. But if you make your own login account as a provider, you can access it. But filling out the Repatha Ready form basically links the patient in with a program that not only provides education, but quicker access to the medication than they would have by going directly to a pharmacy, for example. And in fact, in our clinic, we're only sending patients through the Repatha Ready form. And so the LU code indication, so the LU code of 527 is a fairly long list. It's fairly easy to look up, but effectively patients have to have definitive or probable heterozygous FH, either by Simon Broom, Dutch, or genetic criteria. They have to have an LDL-C greater than 2 despite maximal statin and ezetimibe, or they have to have documented statin intolerance. And statin intolerance is basically defined as a CK value of greater than 5 times the upper limit of normal that goes away when you come off of the statin and comes back when they are rechallenged. After starting the PCSK9 inhibitor through an LU code, you would have to check the LDL in about 1 to 2 months to ensure that there's adequate reduction. And so thinking about what those criteria are, really the key take home point from this and the following slide, which are just the Simon Broom and Dutch criteria, are that there's certain LDL cutoffs that a patient has to have met, and they have to have some type of family history in a premature manner or a family history of dyslipidemia. And in terms of the values for Simon Broom, most patients are it's a little bit easier to get patients in by the Simon Broom criteria, the LDL greater than 4.9, whereas the Dutch criteria is a little bit more tricky to get patients in. But anyways, you can look at both of those. They're both an example. And what I put up in this red box at the top is for patients that you're seeing in clinic with dyslipidemia, and you can consider doing what we, or Dr. Abramson calls back calculating the LDL. So for most patients who are on maximally tolerated statin, we would expect their LDL to reduce by about 50%. So basically multiplying a patient's current LDL on maximal statin by 2 effectively would give you what they would have in the absence of statin therapy. And that also does work when applying for coverage. We also send most of these patients with profound dyslipidemia for genetic testing anyways. The genetic testing is very easy. It's a Trillium Health form. They basically take it into a lab where they get their blood work done for other purposes. It takes one patient who's come back positive, and this is what we would actually expect. So we're not endocrinologists, but from a lipidology perspective, the event rates or the likelihood of having a genetic abnormality causing dyslipidemia in a heterozygous FH patient is fairly low. But if they do have it, then it obviously has implications for their family and for health insurance coverage. Another PCSK9 inhibitor that we prescribe when a patient has drug coverage is inclisiran or Leqvio. This is a medication that, it still doesn't have cardiovascular outcome trial data per se. It has a combination studies. But Leqvio or inclisiran is good for patients in the primary prevention group who are needing lipid lowering for profound dyslipidemia or possible or probable heterozygous FH or definite FH. And the reason that we use inclisiran is really for patients who travel frequently or snowbirds, just by nature of how it's prescribed. So this is a great medication for patients who are going to be out of the country for several months. You prescribe it basically using another enrollment form, and it's 284 milligrams. It's a single pen. Through the form, they get linked up with a pharmacy that's close to them that will dispense it for them, and often will actually inject it for them. And they are given it at 3 months, or at the first dose, then 3 months, and then every 6 months thereafter. And so the out-of-pocket cost is somewhere in the realm of $8,000 to $9,000 in the first year. And then it goes to about 5 to 6 in subsequent years. And the reduction in price is obviously just because they're not getting as many dosages in subsequent years. Private insurance is really good. And again, this would be sort of a secondary option for secondary prevention. This is typically used in primary prevention at this point. And so going back to our case, we've now, followed Mr. B for maybe a year or so, and we've started him on ezetimibe, and now we've started him on PCSK9 inhibitor, and we're quite happy with his lipid lowering, but his triglycerides remain high. And so in that case, we're thinking about starting Vascepa. And Vascepa is a highly purified and very stable EPA ethyl ester, and it lowers triglycerides. And large randomized studies have demonstrated that either a high fasting or non-fasting high triglyceride levels are associated with increased cardiovascular disease. And the exact mechanism of Vascepa is not well understood, but it seems to basically lower expression of inflammatory mediators, TNF alpha. It reduces arterial stiffness, it can reduce plaque volume, and it reduces atherogenic lipid levels. And the landmark trial for icosapent ethyl, IPE, or Vascepa is the REDUCE-IT trial. And so this is a study looking at nearly 8,000 patients, and they were prescribed 4 grams BID or placebo. They had to be between 45 years of age plus, have a history of coronary artery disease, and that's most of the patients in the trial. And then about 30% of the patients were 50 years old with diabetes plus a cardiovascular risk factor. Most of them had a triglyceride about 2.5, so much higher than the 1.5 from our guidelines. And LDL was 1.9, and HDL was about 1. And so the primary efficacy in patients taking Vascepa was a combination of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, and unstable angina. And it occurred in about 17% of patients on Vascepa versus 22 patients in the control group. And so the number needed to treat to prevent one cardiovascular event is 21, which is pretty significant. And the death from any cause was also reduced in patients taking Vascepa. So a death from any cause is about 13% in patients on Vascepa versus 17% in patients on taking placebo. And clinically, Vascepa is quite effective. So if we compare it to other lipid-lowering therapies, statins, PCSK9 inhibitors, et cetera, the REDUCE-IT trial demonstrated over the 5-year follow-up that there was an absolute risk reduction of about 1.3%, which in comparison is much more significant than other lipid-lowering add-ons. In Ontario and in Canada, we need to fill out the exceptional access. And so the criteria for that is a patient needs to have be over 45 with cardiovascular disease. There's no primary prevention indications by EAP. And they have to have strict criteria in terms of their lipid profile. So fasting triglycerides have to be between 1.7 and 5.5. Their LDL needs to be between 1 and 2 points higher than that or lower than that. They may not be eligible, can apply for further exceptional access. And all of these values need to be measured on stable, maximally tolerated statin dose. In terms of counseling and dosing, it's prescribed as 2 grams twice daily. And if the patient decides to pay out of pocket, it's about a $300 cost per month, and some drug plans will cover it as well. In terms of educating the patient, inform the patient that this is not a replacement for a statin. It's not the same as taking a lot of over-the-counter fish oil. And I've had a number of patients tell me that's a very, very big and pill that's difficult to swallow, so that can be something to raise with the patients as well. Some patients experience minor GI upset, increased bleeding, and then there's a small increased risk of AFib, both in terms of incidence as well as severity, most commonly in terms of severity in patients who already have AFib. And so our first case summary is basically we followed our patient who had first cardiovascular event with dyslipidemia. We started him on ezetimibe, which lowers LDL by 25%. And in most patients, that will be sufficient, and we can stop there. Around the same time of treating ezetimibe, you can think about triglycerides and do it at that point. And if the triglycerides are greater than 1.5, you could add Vascepa. And then at that kind of second or third follow-up visit, if LDL our cholesterol panel remains above the threshold to add on therapy, you can consider PCSK9 inhibitors. And so now we're moving on to case 2, thinking about the residual risk beyond the lipids, and thinking about diabetes and some obesity-guided therapy. And so we're thinking about or seeing a patient, Mrs. R. She's a 58-year-old woman. She has type 2 diabetes. Her BMI is 33. She's on metformin, perindopril, and atorvastatin. She's also taking some hormone replacement therapy. Her labs demonstrated an HbA1c of 7.8, normal eGFR, normal cholesterol panel, no BMT is normal, and she has no heart failure symptoms. And so just right off the bat, thinking about trying to reduce her risk of something that we can do on the first day that we see her is just taking away things that are harming her. And so hormone replacement therapy in women who've had a cardiovascular event is thought to be contraindicated or extremely high risk because of the pro-inflammatory and prothrombotic enhancement of hormone replacement therapy. And so that's a patient that we would say that the risk really outweighs the benefit. And this is in keeping with guidelines. And so in all patients who you're seeing, it's hormone replacement therapy is quite topical in medicine and family medicine right now, and a lot more patients are being prescribed for purposes beyond what the indications are by guidelines, which is vasomotor symptoms being prescribed for skin and hair and various other symptoms, which I appreciate patients are very attached to their hormone replacement therapy. But the risk of recurrent MIs, pulmonary embolisms, DVTs, strokes is much higher in individuals who've had an event before. And so that's a medication that we would stop right away and or recommend that she stop right away. And then we'd also be addressing her other risk factors. And so she has diabetes. Her HbA1c is above target. Cardiovascular outcome trials have been discussed many times in the rounds that I've seen over the last year. We know that there's SGLT2 inhibitors, GLP-1 receptor agonists, both of which have cardiovascular benefits as well as renal benefits. And here's sort of an outline over the last just over 10 years of event trials. And so we'll talk first about GLP-1 receptor agonists. GLP-1 receptor agonists are incretin-like hormones. They basically minimize a patient's improves their satiety, reduces their appetite, increases how they are managing excess calories. And in doing so, it basically reduces their adiposity, reduces their weight, and in doing so, reduces hepatic steatosis, reduces albuminuria, reduces eGFR. Blood pressure can reduce as well. There's a reduction in atherosclerotic plaque development, and there's also an improvement in stability. The primary landmark trial in diabetics would be the SUSTAIN-6 trial, and this took patients who were diabetics with an HbA1c over 7%, with cardiovascular disease or over 60 with subclinical disease, and it started them at 0.5, tried to get them up to a target dose of 1 milligram, and cardiovascular disease was defined as typical as well as subclinical cardiovascular disease was defined as microalbuminuria, hypertension, LVH, and in combination, the composite endpoint of cardiovascular death, non-fatal MI, non-fatal stroke was reduced by about 26% in patients on semaglutide. And in the non-diabetic trial, we have the SELECT trial, and this study looked at patients who were non-diabetics with pre-existing cardiovascular disease and started them at 0.24 and reached a target dose of 2.4. Patients had to be 45 with a BMI of at least 27 and a history of a cardiovascular disease, which was prior MI, stroke, or peripheral arterial disease, or history of revascularization. And there was a 20% relative reduction in MACE versus placebo. And so again, similar sort of Kaplan-Meier curve demonstrating a reduction in primary composite endpoint, reduction in heart failure, and reduction from death from any cause, no death from cardiovascular disease. And so this is a beneficial therapy for patients who have had a history of ASCVD, who have diabetes or obesity. And these results have been demonstrated again through meta-analysis that demonstrate a reduction in MACE across the board. And so in terms of prescribing and counseling, the dosing is 0.25 milligrams. You prescribe it for 1 month, and then you up titrate to 0.5, give them another month of that, and then up to 1, and then they can slowly inch their way up to 2.4. You can do further stepwise increases beyond the 1. By LU code, it's indicated only in type 2 diabetics after metformin failure. And in non-diabetics, really only in patients who have private insurance, and the out-of-pocket cost is about $200 to $300. Interesting to note that in the studies, there's about a 30% withdrawal rate due to side effects in some of these studies, and some of those side effects are associated with significant nausea, so counseling the patient to have small meals, vomiting, so taking some ginger or avoiding strong smelling food. There's issues with diarrhea, so increasing fiber intake, and then issues with constipation. So again, fiber intake, water, but some patients need PEG. Patients are not supposed to use it if they're pregnant. And then there's a risk of hypoglycemia if they're on insulin or secretagogue. The second cardiometabolic therapy that would be indicated in a patient with diabetes and cardiovascular disease are SGLT2 inhibitors, and I think this is fairly well established and discussed frequently. And SGLT2 inhibitors have a wide range of effects on cardiovascular disease in terms of reducing adipose, reducing steatosis, changing glycemic control, reducing plasma volume, improving natriuresis, increasing glycosuria, and reducing albuminuria, and improving renal function. There's a significant reduction in CV death or heart failure hospitalization, or CV mortality in individuals on SGLT2 inhibitors. And so prescribing them in Ontario, I think, out of practice, for whatever reason, I've always had a favor of prescribing empagliflozin. But for most patients who would have to pay out of pocket, dapagliflozin would probably be ideal because it's no longer, it's now a generic, and so it's less expensive or less costly. In terms of SGLT2 counseling, there's the counseling that you need to do for every patient. So there's a risk of genital mycotic infections, volume depletion, hypoglycemia, diabetic ketoacidosis, and amputation. And some of those risks are fairly easily mitigated. So genital mycotic infections, hygiene, discuss how it's working. They're, urinating sugar, and it's a kind of a dark and damp area. It's ripe for fungus to grow, and they actually don't need to stop the medication. Many do, but you can give them topical antifungals. There's a risk of volume depletion, risk of hypoglycemia if they're on the insulin or secretagogue, and there's a risk of hypoglycemia in patients who have low EGFRs. There's a risk of euglycemic DKA in patients with type 1 diabetes, and then there's this unclear risk associated with clanogaflosin. It's obviously, or maybe not obviously, but it's one of the sad man's medications that we learn about it back in med school, to make sure that a patient knows to hold it if they're feeling unwell. And in terms of mitigating the insulin or hypoglycemic risk, if a patient's on insulin or secretagogue, then you basically evaluate what their HbA1c is. So if their HbA1c is greater than 8, then you're probably okay and can continue. However, if their HbA1c is less than 8, then you want to make sure that you've had a thoughtful discussion with the patient about the risk of hypoglycemia, as well as reducing their insulin or insulin secretagogue. And then obviously, I think most patients would also be having a discussion with their endocrinologist if they're on insulin. And so to summarize this portion of the talk, inhibitors have multiple sort of pleiotropic effects or benefits in terms of reducing risk of MI, of stroke in the context of GLP-1 receptor agonists, cardiovascular death, HFpEF, and reducing risks associated with diabetic CKD. And so in summary, in our young patient of 50 years old with diabetes, we wanted to make sure that we stopped the added risk that she was giving to herself. So we stopped her HRT. We wanted to make sure that her lipids were at target. They were, so we didn't need to add ezetimibe or PCSK9 inhibitors. And then she has diabetes, and so we want to make sure that we're initiating some metabolic protective medications for her. And now to totally change focus, and I talked about secondary prevention predominantly because the audience of this talk is mostly cardiologists, so you're mostly seeing secondary prevention. I wanted to make sure that this sort of bread and butter was discussed. And then kind of changing gears and talking about primary prevention, maybe a patient who you're seeing for valvular disease, for example, who you're also assessing their lipid panel. I wanted to make sure that everyone is aware about lipoprotein A and what its implications are to a patient's health. So again, we'll look at a quick case. So let's pretend we have a patient, Miss L. She's a 52-year-old female. She's healthy, non-smoker, normotensive. Her BMI is normal. She has a family history, though, of cardiovascular disease. But she herself has no personal history. Her LDL is high than any target, but in the primary prevention context, this is actually a normal LDL, but her Lp(a) is higher. Her family doctor had organized a coronary artery calcium score, which seems to be is more common these days, and so we need to discuss her cardiovascular risk. Inputting her data into Framingham risk score, which is what's recommended in the Canadian context because it's validated here, puts her at a fairly low risk, so only about 4% 10-year cardiovascular risk. And so if we look at this primary prevention flow sheet from the lipid guidelines, there's this tiny little box that has a lot of words in it. And in this tiny little box, we think about the risk of in low patients. And so she really is truly low. There's the patient population who's about 7 to 10%. We think about borderline. And in her 4% risk, she doesn't have an LDL over 5. Her Framingham risk score is low. She doesn't have a really high LDL in the context of 5 to 9%. She does have other risk modifiers, which is this higher Lp(a). So apolipoprotein A is an LDL-like particle with an ApoA bound to an ApoB. It basically looks like the atherogenic LDL molecule, but it's about 6 times more atherogenic than an LDL particle on a per particle basis. It's 95% genetically determined by the LPA locus, and it's not modified by diet or lifestyle. It's independent risk factor from MI, stroke, aortic stenosis, and most current therapies aren't lowering LDL or LPA. PCSK9 inhibitors do lower LPA slightly, and then apheresis shows a modest effect, but I have yet to see any patient who's had apheresis. And so per CSS guidelines, we only need to screen a patient once in their life. And across, internationally, the recommendations for LP(a) vary. And so in Canada, we're doing it at least once. We're kind of in this middle section here right across. But in Canada, we recommend checking it once in a patient's life in all individuals, regardless of family history. And we're doing it predominantly to help optimize and treat cardiovascular risk factors. You can see that different population, not different populations, but the American and the European guidelines have different reasons, but most of them, or a lot of them, are doing it for at least for patients with a family history of premature cardiovascular disease, because it's implicated in that, as well as in many cases, at least once in a patient's life. And it's to help reclassify a patient, as well as to identify patients who are at higher risk of cardiovascular disease. And LP(a), as I mentioned, is nearly about 6 times more atherogenic than LDL. And in keeping with that, patients who have a high LP(a) are more at risk of ischemic stroke, myocardial infarction, or heart failure. And I basically followed patients for about 7 years and demonstrated, chat. Yes, 5 minutes left. I know, I'm almost done. That there's an increased risk, nearly twofold risk, as the LP(a) rises above 117 was their value. And this value threshold in terms of abnormality varies depending on the study. But in Canadian units, 125 nanomoles per liter tends to be the new cutoff for normal. CSS guidelines is using 100 nanomoles per liter. And the relevance of the CAC scoring is a bit unclear. So we know that in patients who are followed for a longer period of time, so this is a study looking at a combination of the MESA study and the Dallas Heart study, patients with a high LP(a), so this is the highest quintile. So LP(a) is broken down into 5 groups. Those in the highest quintile with a normal CAC score still have relatively low event rates. So a 3.4% event rates in the 10-year period. But this was significantly different than those who had normal LP(a). And so there is some residual risk despite having a normal CAC scan. And so when we evaluate her risk, we're basically thinking, well, her LP(a) is increasing her risk somewhere in the realm of about 2 to 3-fold, depending on the study that you look at. Her ApoB is a little bit above, is a little bit high. She's got a family history, which again is a bit of a risk enhancer, but she has a normal CAC score, and that's lowering her event rate. She's young, she's a female, and so how are we going to combine all of this risk? And so in some patients, we do a lifetime analysis. So there's an LP(a) clinical guidance tool, and this basically allows us to calculate a patient's lifetime risk. And so in terms of management, we'll have a discussion with her about lowering her risk by treating her with a statin therapy, which minimizes her residual risk, and in aspirin. And so most of the studies are fairly binary in patients with a high versus low Lp(a), given aspirin versus no aspirin. The addition of aspirin in a patient with high Lp(a) will lower their risk down to baseline or normal Lp(a) risk. And so, do you have a patient with a high Lp(a)? So we've got two studies going on right now. The first is going to be looking at Lp(a) targeted therapy, and this is basically going to be any patient with an Lp(a) over 175 who's had a cardiovascular event or is at risk of cardiovascular event. And then we also are running a registry, and those are in patients with an Lp(a) over 125, not necessarily, but about over 125. This will just follow patients prospectively. And they just need to be able to be willing to be followed and being able to sign a consent form for the registry. So if you have any patient with a high Lp(a), please send them on. And so, excuse me, to summarize, so we looked at some lipid optimization and secondary prevention. We did a bit of a stepwise algorithm as per guidelines, basically started with the statin, up titrated it to maximal, added ezetimibe, and then added PCSK9 inhibitors. We were able to get them below the threshold to further intensify. And in patients with a high triglyceride level in secondary prevention, we can add Vascepa. And in patients with diabetes or obesity, we consider GLP-1 receptor agonist. And in patients with SGLT, or patients with diabetes, consider SGLT2 inhibitors, but also if they've had they have renal disease or if they have any form of heart failure, then SGLT2 inhibitors are a great choice. In terms of primary prevention, I'm hoping that most of you will at least checkbox or add in Lp(a) to your lipid screening if you haven't done so already, and we'll be able to counsel your patients briefly on this added risk. So thank you so much for your time. I'm all done.